Well, hi guys. It's Kevin, the fourth best paramedic practice educator on the island. Today, I just thought I'd take a chance to talk to you guys about vomiting, everyone's favorite topic. So, vomiting, puking, barfing, throwing chunks, whatever we want to call it. Probably use vomiting in your PCR, to be honest. It sounds a little better. But it's something that's actually mediated in the brainstem, in something called the vomiting center. And the vomiting center is kind of like the brain of vomiting. It decides whether we're going to vomit or not. How it does that is it gets input from a few different areas. It gets input directly from the gut. It gets input from the vestibular area of the inner ear, sort of associated with dizziness and motion sickness a little more. And then it gets input as well from something called the chemoreceptor trigger zone, or CTZ. And that's an area of the brain where the brain actually gets a chance to sort of sniff the blood as it goes by. It kind of checks and it gets a read on, hormones and drugs in the system, and it provides some input to the vomiting center about what's in there to help the vomiting center decide if you're actually going to throw up. So there's a lot of different ways that the vomiting center can kind of decide on that, and there's probably a bit of a balance between all those things before the decision is made, in the brainstem to actually throw up. But how it gets those inputs kind of differ in various ways. And that's why we have a couple of different drugs now to help us deal with that. So the first drug to talk about is Gravol. We've had Gravol or dimenhydrinate, I'm going to say Gravol anyways, for a long time in PCP scope. And Gravol itself is actually just a combination of two different drugs. It's actually a combination of diphenhydramine, which is Benadryl, and something called 8-chlorotheophylline, which is kind of like caffeine actually a little bit. And those two were put together and it was called Gravol, and it was marketed back in the 50s, I think, or something like that. The reason they put that, the sort of caffeine-like derivative in there is, I think, to sort of help with some of the sleepiness that comes along with Gravol administration. Whether it works or not, I've never seen it. But anyways, that's what happens is you have those two, they come apart, and then you have the diphenhydramine in your body as well, which we'll talk about more in a second. So Gravol, its effects actually have a couple of different effects. It has what's called an anticholinergic effect, and that's something where the drug actually blocks the action of a neurotransmitter called acetylcholine at certain sites. And it also has an antihistamine effect where it blocks histamines, which cause, sneezing, allergies. They trigger some of that vestibular area to tell the vomiting center to throw up. So the effect of those histamine and anticholinergic both sort of suppress that vestibular area and perhaps the vomiting center a little bit as well, and try to tamp down that urge to vomit. When we give Gravol, it's actually probably, you're going to see the bang for the buck probably with motion sickness, inner ear, dizziness, that sort of thing. That's where you get the most effect from giving somebody Gravol. In somebody who's acutely vomiting, like when you show up, they're acutely vomiting on scene, Gravol's probably really not going to work quickly, and it's not going to really get you where you want to go, but you're still going to see the negative effects of Gravol. Negative effects mostly are centered around kind of the sedation that we see, and that's why we have a lower dose for sort of elderly patients or frail patients. The normal dosing for Gravol is 25 to 50 milligrams, IV or IM. And if we're giving it IV, we want to make sure that we're diluting that 1 cc or that 50 milligrams, or half a cc, 25 milligrams. We want to make sure we're diluting that right out to 10 cc's before we push it in the IV, because it's quite irritating and we don't want to irritate the vein. It's not really diluting it if you just give the milligram and then flush it. That doesn't really count. You actually need to dilute it in the syringe itself. Obviously, if we're giving it IM, you're not going to dilute it. You're just going to give the half a cc or 1 cc, 25 or 50 milligrams with the appropriate needle intramuscularly. In older people, or maybe people with cognitive disabilities, head trauma, low GCS, giving Gravol is really, we ask that the dose be even lowered to 12.5 milligrams, but you might want to at that point consider whether you really need to give the Gravol at all. Like I said, it's really going to be effective with motion sickness, people who are going to be in the back of the ambulance or maybe prone to it, or maybe have a little bit of nausea on scene. But it is not something that needs to be given all the time to everybody who might just have the slightest bit of nausea. Sometimes you just need to throw up. We give a lot of Gravol in BCHS. The stats from last year, actually, I took a look at them this morning. And in roughly 40,000 entries in an Excel sheet that I got, PCPs and ACPs, no, I think it's specific to PCPs actually, the data I got. is was actually our total dose for the population of British Columbia last year was 1.8 million milligrams of Gravol that we gave out. So that's a lot of Gravol. I mean, I think it was probably all of it was given for the right reason with patient comfort in mind, but we have to assume that we're seeing some negative effects if we give a lot of Gravol to people. So I would just ask that we sort of really consider if Gravol is needed in a given situation and only give it if we really think we're going to encounter those problems. That kind of takes us to talking about ondansetron, which is a great new addition to PCP Scope. And if you haven't done the training, go and do it. Just a little online training there. But ondansetron, 4 milligram tablets, they're minty, they're delicious, easy to give to somebody. They dissolve in the mouth very quickly and get taken up by the body very quickly. Are probably a little bit better for somebody who's actually vomiting, with a chief complaint of vomiting. So I think it's going to be a little bit more effective. You'll see in the training there is some downsides to it as well. You really want to be careful of it maybe in pregnancy, especially first trimester. And you want to check for something called long QT syndrome, which is just something where on the ECG, you can actually see that one of the intervals between the QRST, the QT interval actually gets longer and longer, which can be dangerous for some patients. And some people, sorry, bug just flew in my ear. Some people actually have a long QT anyways, but we want to make sure we don't make it worse. 4 milligrams is going to be a pretty safe dose. In most people, you can give 4 milligrams of ondansetron, you're not really going to have a problem. Some of the QT prolongation kind of comes in as you get bigger and bigger doses in hospital, but it's something to be aware of, especially if somebody has a history of long QT syndrome. You might want to avoid giving them the ondansetron. So, when should we give the ondansetron? Active vomiting is kind of really where you're going to get the bang for the buck. Something that's maybe not associated with the inner ear and the vestibular thing, where we know that the Gravol might work a bit better, but maybe something that's mediated more by touching that chemoreceptor trigger zone or coming from the gut itself and that need to vomit. So then go ahead and do it. I got a question saying, well, can I give both? And the answer is, yeah, you can give both. If you give some Gravol at the scene when somebody has a vague complaint of nausea or you're worried about motion sickness, that's fine. You go ahead and give them the Gravol, you transport, maybe a half hour later they start throwing up. Well, it's safe to say that the Gravol didn't work. So now what we might do is we might say, would you like some ondansetron? It might help with your vomiting. And assuming it's the right thing to give, yeah, go ahead and give it. What I wouldn't do is just walk in with a shotgun approach and give both at the same time right away. I'd really consider which drug is going to be best at the time and go ahead and give that. Another question I got about Gravol actually is, can Gravol be given in the setting of anaphylaxis? And well, the answer is sure it can if you have nausea and vomiting. Even the fact that it breaks down into Benadryl isn't going to make too much of a difference for you. So you really might want to consider whether giving the Gravol is the right thing to do, because you're still going to get a sedative effect and it's not going to help any aspect of your anaphylaxis. And the up-to-date article on anaphylaxis is a good one to take a look at to just check in on that as well. So yeah. So we've covered off the administration of ondansetron and Gravol, and we talked a bit about the dosing, and I just want to be sure that you guys are really happy with deciding when you're going to give which one. I just encourage you to think about it. Think about the drug you're giving, think about the potential downsides, and if you have any questions, please reach out to a practice educator and we'll be happy to answer them. So thanks very much and talk to you soon.